It's my great pleasure to welcome Professor Adam Fox from London to our podcast tonight. Professor Fox, it's a great pleasure to speak with you.
Lovely to be here. Thanks for inviting me.
You wear many hats. Some people would say you are a perfect representation of the British government in this space. But one thing I'm mostly fascinated with your activities is you are the only allergist I have ever seen to champion the NGO cause. Why are you so helpful to the NGO community in England, and how come you're the only one?
I really don't think I am the only one. I think maybe I'm more on social media than some of the others, and maybe it's a generational thing. But I'm very much standing on the shoulders of giants from the past in the UK. Uh, j- I've thought myself a little bit about why sort of I've gone down this path of just trying to make things better for everybody. Because the one thing I can tell you for sure is it does feel like you're banging your head against a brick wall a lot of the time. We've got such an enormous burden of disease with allergy in the UK, and it's growing. And I think we're up with Australia at the top of the league tables of the prevalence of any allergic disease you choose to think of. Yet our provision within our National Health Service is really poor. And I suspect that where my own sense of sort of the need to do comes from is purely the coincidence of timing. Because when I got into this field, when I first made the decision to start specialist training within allergy, I was at the beginning of my training as a general pediatrician, which is what we all do. Um, and then you have the opportunity to subspecialize. And my first training post was in 2003 under Professor Gideon Lack, who's become a very close colleague and friend. And it was the same year that I started that there was the publication of the first report by the Royal College of Physicians in the UK that it was called The Allergy, the Unmet Need. And it was the first time somebody had really articulated the enormous mismatch between this burden of disease and the provision of care in the UK. And it was so stark that there were so many people who needed, deserved, required a better access to care and just weren't getting it in the National Health Service for all sorts of reasons. And as I read this report, because I remember people talking about it in the first, must have been the first week or two of my training starting and me being immersed in allergy, I was absolutely in my role living exactly what this document was describing. Because as part of my training, we were passed around different specialties to get better training. So I would be not just in the allergy clinics observing Professor Lack, but I'd also be in dermatology clinics and ENT clinics and respiratory clinics and general pediatric clinics, gastro clinics, all these different specialties. And I was seeing the same kids. And as things went on a little bit, and I was not just observing, I was actually helping in the clinic and seeing the patients, I would find myself having to refer the children, for example, in the dermatology clinic with their significant eczema to see myself in the allergy clinic because of their food allergy, and then to see myself again in the respiratory clinic because they all had comorbidities. They had multi-system allergic disease, as so many children with significant allergies do. And you just couldn't deal with their eczema in isolation of their food allergy. And you couldn't deal with their food allergy in isolation of their asthma. But within the confines of those clinics, you had such a short period of time to see those patients, and the clear focus of the other staff around you, that the culture of the clinic was all about, we're not interested in hearing about the eczema in the asthma clinic. We need to know about their asthma. We need to give them steroids for their asthma and make that better. But nobody was thinking about the impact of their upper respiratory symptoms, because they were saying, no, the ENT guys deal with the rhinitis. So you ended up with these children who not only were having incredibly inefficient care and being passed around from one specialty in one clinic to the next, but a lot of them, because of that fragmented care, were being given an enormous amount of steroid medication because the ENTs were giving it for their rhinitis, the respiratory guys were giving it for their asthma, the dermatologists were giving it for their eczema, and nobody was thinking holistically about these children. And the only place that you could even begin to try and pull all of this together and try and do things in a joined up way was the allergy clinic. But the allergy clinic had become so focused just on food allergy, with no space for anything else, that it really needed rethinking. And that was where I was very much inspired by the model that Professor Lack had set up at St Mary's, that created this very much this one-stop shop environment where you could address all of these different concerns. You had around you, you had the facilities to do skin testing and get immediate results. You had specialist dietitians in clinic. You had all the support to be able to actually address these kids' proper needs, but in a joined up way.
It's absolutely inspiring, I guess, coming from Australia and looking at Britain in many ways. The National Allergy Strategy, which you are heavily involved in right now, calls for a lot of improvement in the British healthcare system now in 2025. What would you like to see? Now, there is a call for public input in the UK, which I think is fantastic. It's clinicians and the people together and the NGO community trying to make things better. If you would like to see three main things improve in the next 5 to 10 years as part of this strategy, what would those be?
Okay, that's a great question. And it's worth mentioning that a lot of our inspiration has come from the work in Australia and the National Allergy Strategy that was done about 10 years ago there and has made enormous progress in some areas as a consequence of joint working. And I think this coming together of the allergy charities, the specialist society, and in your case, but not in our case, genuine endorsement by government, which is something that we've been flatly denied. They're involved, but they won't commit to saying we're going to do what you suggest we do, and no commitment of any sort of federal funding for our projects. So we can only really aspire to achieve what you guys have been able to do. But I think number one would be proper representation. And what I mean by that is just ensuring that the voice of the allergy community is at the table when it comes to policy development and organizational development and strategic commissioning, for example, within the National Health Service, because up until now, we're just not on the list. So, amongst all the major specialties, whether it's cancer or diabetes or hematology or rheumatology, all these multitude of different specialties, we've just been the poor relation for a long time and not really had a seat at the table. But it needs to go further than that. And if I'm allowed to include this all in my first ask, it's in wider public policy, so that when people are developing policies around public-facing issues of food labeling, around management of chronic diseases in schools, that again, allergy is in there and considered, but not just considered by people who don't really understand it necessarily, but there are representatives of the allergy community involved in the co-development of those policies. So that would be number one, just having our voice at the table, because it's been, noticeably absent, and that's really clear from the way that policies have been developed over time. I think number two is better access to specialist care, and that's very broad. So that doesn't just mean loads and loads and loads of specialists. Firstly, because we've been trying to fight that fight for some years and we're not getting anywhere and we're not going to, and there is enormous resource restraint, which means that this idea that we're suddenly going to have this explosion of new allergy doctors, it's just not going to happen. What we really need is way better education amongst general practitioners, amongst secondary care doctors. But that still needs leadership and input from specialists to make that happen. But what we're really hoping is the vast majority of patients who are seen exclusively in primary care have a general practitioner who has been trained in allergy and understands how to identify it, knows when it needs to be escalated, but can actually deal with most things in primary care, because that's realistically where most things should be getting dealt with. And the way the wind is blowing in terms of our 10-year NHS strategy, it's very much about taking things out of the hospital and closer to home and into the community. And that makes a lot of sense. It's cheaper and more efficient to deliver, and it's more convenient for patients. But where it doesn't work for allergy is that at the moment in medical schools, in postgraduate general practice training, there's very, very, very little allergy in there. So understandably, GPs don't know much about it, so they're not well equipped to deal with it. So they either can't deal with it or they try and escalate it, yet there's not the capacity because there's not enough specialists to see all of those patients. So we need a very sort of holistic view of the whole healthcare system to ensure that overall there is better access to trained healthcare professionals who can identify and manage allergy appropriately, and a funnel for those who've got the more severe disease so that they can get access to up-to-date treatments, because there's been huge advances, as you know, food immunotherapy, sublingual immunotherapy for respiratory allergies. Some of these things have got nice approval, meaning that they've been recognized by our National Health Service as being not just effective, but cost efficient. Yet despite that, there's virtually no access to them. And that has to change, because it makes no sense to do the deep dive to understand these technologies, recognize that they're in the interests of everybody to make happen, and then not have the access. And then I think the third thing is better public awareness, because food allergy and other allergic diseases, it doesn't just happen in isolation when you come to your hospital appointment. It follows you around and lives with you all day. And it would be so much better if other organizations beyond, so for example, the Food Standards Agency, who I think have been great in the UK, and they made it one of their missions to make the UK the best place in the world to live with food allergies and food intolerances. And of course, that reflects a whole raft of different things that need to happen. But that mentality, would love to have that whole ethos in schools, in restaurants, in retail, in transport, where they genuinely want to make things better. Because I think for lots of people, it's almost not the condition that's the problem. It's the way that other people respond to your condition. How unhelpful it is when you get on an aeroplane and they're just completely unsympathetic to the fact that you're with a child with a severe allergic disease, that there's genuine fear and anxiety there, and you're in fact just heightening it by a lack of awareness about it. So yeah, not asking for much, but yeah, proper representation at government and policy, policy decision making, better access to allergy care within the healthcare system, and greater public awareness. And I think that sort of broadly covers it.
One of my favorite photos of you is seeing your photo in front of 10 Downing Street holding a petition with at least 40 organizations next to you. And for me, that was really a symbol of practitioners and parents and the NGO community really getting together and having a unified voice. How difficult is it
Yeah.
in the UK to have that voice heard?
Yeah, it's challenging. I mean, the one thing I've heard recurrently from parliamentarians when you speak to them is they say that, if you're not speaking with one voice, it's really hard to make any change happen, because if the same Minister for Education, for example, is getting multiple approaches from different allergy organizations, all saying something a little bit different, the obvious response, the easy, you can't give them any excuse to bat you away, because if you do, that's what you'll get. And it's too easy for them to just say, well, look, we don't know whose advice to take here. You need to knock your heads together, sort yourself out, and tell us what it is you're asking for. So being able to approach them with and education's a perfect example. We had exactly these conversations about the management of allergy in schools, and the Department for Education said, you need to put together a position paper that reflects the view of all of the major stakeholders here. And that's exactly what we did. And in fairness to the Department for Education, when they received that, the consequence has been genuine engagement and an absolute commitment to make things change. Because what we often find when you speak to the people particularly within Parliament and these sorts of organisations, is they get it, and they've got themselves in these positions because they want to make good things happen. They can see why it benefits everybody, and especially because many of these things, we're not asking for money. It's just changes in policy, and in fact, some of these things have significant cost savings attached to them. So there is a sort of there's a door that's open if you can push on it, but it needs to be absolutely clear what everybody wants to do, and there has to be that unified sense of purpose and clarity about what we want to change. And for me, that's been the biggest thing, is pulling everybody together so that we can say, look, this is a strategy that, look, all it's doing is bringing together a load of strategic objectives and priorities, but it does reflect the voice of all of the people involved. And that's really, really important, because that's a big step, and it gets us past that, well, you don't really know what you want. So, and it's not until you're able to articulate that we can really have a sensible conversation. It's now, okay, now let's talk about how we can make some of these things happen.
I think in Europe, Britain is definitely leading the way, because that is a common problem with food allergy communities in almost every country in the world. And Britain and the United States and Australia, to an extent, have made those strides in the right direction, if nothing else. But that leads me to the question about oral immunotherapy. even though OIT is not a cure, it is the closest thing, according to the European Association, that we have to a better quality of life when it comes to managing food allergies. What's your take on it, given that you're one of the pioneers in Europe in this space, and looking back to where you began and now, how much has this OIT field in the UK progressed in terms of options and choices for the families?
Yeah. If I reflect back on how things were when I started in the field, so nearly 20 years ago, it is so profoundly different. We have genuinely transformed from being a diagnostic specialty where all we could do is give you an accurate diagnosis and just say, well, you're just going to have to avoid all of this stuff, to start to now in a genuine sort of situation where we're able to offer not just a treatment, but a range of treatment options, which comes with its own challenges. A regular consult, which used to be, well, let's do some testing and this is what you're allergic to. Here's how to use your adrenaline pen. Speak to the dietitian about food labeling and see you in a couple of years, and let's cross our fingers and hope it's all gone away. Now becomes a conversation where we have to not just do all of that work, because it remains fundamentally important, but discuss the opportunities around oral immunotherapy, using biologics, and how all these emerging therapies like sublingual immunotherapy, epicutaneous immunotherapy, there's a real menu of things. And in fact, it presents a real challenge about ensuring that we don't sink into what's easy to do, which is a sort of patriarchal sense of, I've decided what's best for you, so I'm only going to tell you the option that I've decided, to genuine personalized medicine where the families are an equal partner in deciding what is the best treatment modality for them. That takes time, and it needs patients to understand all of their options. So increasingly, we're spending time developing resources for families. And I'm certainly now sort of stepping back a little bit from trying to cram all of that into initial consultation, even though time is of the essence, because when you make a diagnosis, the last thing you want to be doing is saying, well, let's put some barriers in so that there's much longer before we can initiate treatment, which works better the sooner you start. But just making sure that we've got all the right resources so that we can say to patients, look, we've got a clear diagnosis. For now, you're going to have to avoid this, but there's a range of options of what we do next. And here's some supporting information. Have a good read of it, and let's reconvene pretty soon afterwards to start making decisions about what we do in interventions. Because intervention, especially in early life, can be so transformational. And of course, we're not allowed to use the word cure, but for many of the infants that we diagnose and quickly start on oral immunotherapy, the outcomes feel very similar to that, because they are able to introduce the foods back into their diet. And that includes, for allergies like peanuts and tree nuts and things that previously we would have simply considered as being something that's going to be with you for life.
As a mother who had an infant who had anaphylaxis at the age of 3 months, to the first time or second time, really, formula introduction, and now she reached food freedom after undergoing OIT at the age of 8 for milk and egg. It was fascinating to remember that at that first point of realization what anaphylaxis is, in the emergency department itself, there is not enough information. Parents are
Yeah.
not given anything meaningful at that first point of emergency department, let's say, contact. And there is a lot of talk in Australia how that could be improved, because by the time you see the specialist, it is at least 3 to 4 months at best,
Yeah.
privately. Publicly would be even longer.
Yeah.
Therefore, I can completely identify with my own story in that. But what I was really fascinated also in Dallas, in June this year, I went to Dallas and I met 7 British colleagues at the Food Allergy Support Team's annual meeting of physicians specializing in OIT and SLIT. And that was fascinating. 7 different doctors from the UK space came and presented their stories. And there was nobody else from Europe. That was the European delegation. What do you think of this intercontinental collaboration in this space? Is it getting better, and how can we make Europe, in a way, more collaborative in itself in that space?
Yeah, it's give you a bit of context. It's probably worth saying that those 7 people that visited are almost the entire cohort of people who are doing this. So it doesn't in any way, sadly, reflect a much broader sort of culture of immunotherapy quite yet, but it's definitely growing and it's getting traction. And inevitably people are speaking to the patients who go off and get it done, and then they're seeing the results, and you can't ignore those results. And inevitably patients will vote with their feet. But one of the things that I've really loved about getting involved in this area of allergy has been this incredibly collaborative um, atmosphere that means that we've got these email groups that are full of people who are just delighted to share their own experiences, together with share their difficult cases, and then find people from all over the place, particularly the US, so openly sharing, for the benefit of everybody, what's worked for them, their experience, etc. That's fantastic. And I've loved that. And there's a real sense of community amongst people that do OIT. Part of me thinks that maybe the reason it's become sort of stronger between the UK and the US is probably just something as simple as language. That's it. There's not an enormous amount in common in terms of how the healthcare system works. I mean, I think the UK and US systems are pretty poles apart, but communication, of course, is extremely easy, and culturally, there's a lot of similarities. There are a lot of colleagues definitely doing this in France, in Spain, across Europe, and in fact, many of our patients for years before we were doing much of this ourselves were again voting with their feet and not just going to the US. There's a big centre in Lille. There's centres in Barcelona. So. I think maybe we need to do a better job of reaching out to these guys and pulling them into that same community, because I think the idea of having a genuinely global community of practitioners who are just sharing all of their experiences is incredibly powerful and really, really good for patients. But it's also lovely for us as specialists, because you just feel like you're not alone. And it can feel a little bit like that when you're on the, I guess, sort of the front edge of this. Out there. I mean, I think naturally you find safety in numbers as doctors. I mean, my own practice has moved away from having my own private practice towards being in a much larger collaborative joint practice with a number of other colleagues now. And it just makes everything easier, not just the economies of scale of running the place, but just being able to bounce simple things off. Of other colleagues, just having that geography that you're in the same building as other specialists who've got different but very long experiences to myself, to be able to just run through simple cases, bounce questions off them, think about broader topics together, bounce things around a whole big group as a multidisciplinary group, because we have so much to learn from our nursing colleagues, dietetic colleagues, pharmacists, all of those. This whole way of practicing collaboratively is just so much better than the old-fashioned sort of you go off, do your private practice in complete isolation, and as a result can actually come up with some really strange ways of practicing that are completely at odds with what everybody else is doing. So it's lovely to see that as a new treatment like this is emerging and developing, that it's being done it's being done together as a community, which is exactly right.
What was fascinating for me is to find that piece of information that in 1906, a British physician actually did a first known case of oral immunotherapy for egg in that
Yeah,
a 13-year-old boy kept being brought to his practice in London. But he was very sad that even after he published his results in 1908 at the Lancet journal, the other colleagues did not, flock with their letters and to come and learn
yeah,
from him. Why do you think that is the trend? Why does not every allergist want to learn now? I mean,
yeah.
is it because of those silos in which people operate and practice, or is it something else, do you think?
I think there's a number of reasons. I suspect the reason that Schofield, who was literally 200 yards around the corner from where we are now, so we're in sort of quite a historic place for immunotherapy here. Then it was because there probably weren't many patients. I think it was a real curiosity to have a food allergy in those days, whereas it's far from it these days. It's every classroom's got one or two kids with a food allergy in it now. I think firstly, our National Health Service system really disincentivizes any sort of innovation that means that they're going to have to spend more money or needs more patient contact. It's the innovation they're promoting is ones that mean that you see less of your patients. And although there are lots of different ways of doing immunotherapy, some of which require less contact, it's not less contact than it was before, which is when you only saw them to make a diagnosis. So overall, it does need more input, and that's difficult because there's so much restraint on space and staff and any sort of resource to develop anything. So that's one thing. I think another thing is that Look, it's perfectly normal human behavior, to resist change to a degree and feel that we need to be a little cautious. Remember, the first thing that's drummed into us at medical school is first do no harm. And I think for a long time there was a sense that, well, we really needed this to play out more. We needed to get better research, better understanding before we start offering this more widely, because there might be untoward consequences. I think for me, we're sort of at a tipping point where we're more at risk of doing harm by omitting this treatment and letting infants with a food allergy grow up not having been treated, because they then have to bear the consequences of that. And it's much harder to treat and are much less likely to get the outcomes that we're really after. So, I think I'm hoping that now for me that we're sort of beyond that tipping point, things will change relatively quickly. But, you know, medicine, it's a conservative area of it. It takes time for things to change, and you always get the early adopters, and it takes time and for other people to come into line behind it when they're all convinced and they can see the benefits. And I'm hoping that the new centre that we've just established here, we really want this to be an example, a bit of a beacon of saying, look, we can do this safely and look at our outcomes, and we'll certainly be publishing them. And people will look at that and they'll hear the patient stories and those, there's the human stories, behind the numbers that we publish, and hopefully start saying, look, we've got to be offering this to our patients as well.
One thing I love about your approach as a group, from what I've seen on social media, is you do incorporate the psychosocial aspect of food allergy life by having psychologists involved. As a doctor, was it difficult for you initially to grasp that part of immune modulation, that psychosocial aspect? Because that's not often what doctors are trained in. And how did
Yeah.
you come to incorporate that as part of your
Yeah,
therapy practice?
it's so important that we recognise that years ago, but it's so poorly addressed, particularly on the National Health Service. And I remember years and years ago when we first set up our department at St Thomas's in London, essentially having to go to a charity who, by a series of just coincidences, had the funding available for us, and they said, you can do anything with this money, we're keen to support what you're doing and your vision. And I said, this is easy, we just need to get a psychologist in, we need to pay for a psychologist, and we needed to do that with charitable funding in order to demonstrate to the hospital how important it was to our outcomes and the quality of life of the kids. And there was a lot of having to fill out quality of life questionnaires to prove the interventions made a difference, in order to then, when the charitable funding inevitably dried up, to convince the hospital to keep that person on. And in fact, that department has really, really thrived and grown over time, which has been fantastic to see. And when we were setting up our new place, very close to the top of the list of things we need proper in-house psychologists. And I'm delighted that we've got such high quality people involved, who are really embedding themselves into the patient journey. So essentially everybody, when they start being assessed for oral immunotherapy, and the same as you are for, my daughter's got cochlear implants, and when she went through the assessment for that, she had to have a psychological assessment, because there were so many reasons why, if things weren't right, it wouldn't be a good idea to do it. But more importantly, if you go in with the right mindset, you see this very quickly when you do a lot of oral immunotherapy. The right mindset going into things makes a real difference in terms of outcomes and how bumpy that journey is. And so embedding that support right at the beginning, so that you can identify the ones who really need more intensive involvement before they start, or those that just need a little bit of gentle, support along the way, it will make a real difference. And yeah, it was critical for us that was there.
We found that teenagers in particular, when they're pushed by the parents or grandparents initially, they comply. But as the time passes, when they become their
100%. Yeah.
they fight
Yeah.
back. And it's mostly that
Yeah.
almost parental-child struggle that is reflected in the outcomes, isn't it?
Of course, and I say this all the time, even the kids as, relatively young kids, I always say to them when I'm speaking to them, firstly, I'm always very careful to involve the child in these conversations, but always being very clear to say that if it's you, as in the parents, that want to do this, but your child doesn't want to do this, don't do it, because it's not going to work. You're just going to have a fight, and it's going to make everybody miserable. This is about shared decision making, that the child, as soon as they're reasonably old enough to be involved, needs to understand what the benefits are and be up for doing it. And then the whole thing is going to be so much more positive for everybody.
Interestingly, I wanted to ask you about the role of alcohol. Now, that's not something that's very well understood.
For us or the patients?
For older patients, how can
Okay.
alcohol
Yeah.
how can alcohol influence OIT outcomes? Can it influence? That's something that we keep, talking to teenagers about, especially if they get drunk and don't report it on time, and obviously adults as well in oral immunotherapy programs. Does alcohol, in your opinion, really affect that microbiome, or in what ways? How can we balance teenage life and fun with
Yeah.
safety
I
of the
think that's right.
program?
We don't want to be the fun killers that sort of say, sorry, I know you're off to university, but you cannot drink for the entirety of that's not going to happen. And there's no point trying to do that because it's not going to happen. And it's one of these things where you're much better off having open conversations. And our nursing staff particularly very good because one thing, I've learned that it doesn't matter how much we try, that then some of these kids, especially, they're not going to be open with us as the doctors, but they are going to be much more open with the nursing staff that they spend more time with. And they're really good at this, at sort of saying to them, look, we're not expecting you to not drink when you've just turned 17, 18, but we'd much rather that you do it sensibly and that on the days that you're going to be going out and having a few drinks, don't have your dose. Just avoid it. It's fine. And they need to be given permission in front of their parents so that the parents don't start, saying, you can't go and have a drink anywhere because it's going to interfere with your treatment. And them understanding that it's not the end of the world if once a week or even twice a week, they're not having their dose because they're out with their friends. And, that's such an important part of life. It's, there's no point pretending it's not there. So I think the key to that is open communication and being sensible about who the right person to do that is. And actually, it's probably not me as the doctor who maybe doesn't see them all that often. Maybe the right person is the nurses who do see them regularly and have a better and more open relationship with them, so that they can, that they'll be upfront and honest. Because if you don't do it, you get these situations which we had, which is anaphylaxis after dosing because they've had a few drinks and they were under pressure from parents you still have to have your dose. And so they keep it quiet and then have the dose and have a reaction because alcohol's a very potent cofactor for severe reactions.
Thank you for that. I like what you said. We're not fun killers. It has to be all sensible. Um,
Absolutely.
and
Absolutely.
and in terms of vision for your center, you did mention this beautiful multidisciplinary center which has recently opened with different types of services. What's your vision for the center looking ahead?
We really want to just ensure that for the people that are really motivated, that want it, that we're able to offer them absolutely world-class care, that in the most holistic way, that they have an easy, frictionless journey where they don't have to fight like so many people have had to get access to the options that they ought to have, and that they've got the full range of options that, there's we want them to know that they don't need to travel in the way that it's crazy some of the places these people had to go. But then likewise, it's crazy where people are coming from to see us. We have families flying in from Bulgaria and Denmark and Senegal and really we want to create a model of care that these countries can look at and our colleagues elsewhere can look at and say, well, they can do it there. There's no reason we can't do it here. And we're absolutely open to the collaboration that we've been offered by other centres elsewhere that have enabled us to do this. It's an area of medicine where people often start thinking, well, it's private, so it's all about the money. We very carefully ensured that this is entirely clinically led. There are no external investors. This is all ourselves that have invested in this. We've got no shareholders. There's nobody else involved. There's no private equity firm behind it. This is just a group of doctors who have seen the benefits, have set this up themselves. God help us, and I hope I hope it doesn't turn out to be a fool's errand. But to try and do the right thing. And the one thing thankfully there's no shortage of in allergy is people who need help and support and access to better care. So there's no need for it to be a sort of commercially led type venture that we're trying to protect ourselves from competitors, because there's plenty, the more the merrier here. There's so many people who need support. We can't provide it to everybody. All we can hope to do is show a little bit of leadership, demonstrate what we believe is a really high quality model of care, and hopefully that'll result in other people offering similar things elsewhere.
We wish you a lot of luck and success in your new journey, and we would love to
Thank
speak with
you.
you in the future when it comes to your results, when you're at the point of publishing your results.
Yeah, Nina, more importantly, you need to come and have a look around. We're only up the road.
Definitely. Definitely. We're only 2 flights away. That would be wonderful.
Exactly.
That would be wonderful. Thank you very much for today's discussion. It's been inspiring as always, and I hope that our listeners can jump on Instagram. And can you tell us the Instagram name for the center?
Yes, it's at Allergy Center of Excellence, and plenty of links from my own and my colleagues' Instagram accounts as well. Yeah,
Beautiful. Thank you very much, and we look forward to speaking with you next year.
lovely. See you soon.